someone you've been gaming with for years, but have never met.
Gentlemen, mød ledsagelse.
Det er løgn. Topspringer. Jeg har fandme kendt hinanden i 3-4 år, og kun til mødt hinanden og set hinanden før.
If we approach each other, we might find out that we share the same destiny.
Rane og Maha, I kom til Danmark fra Syrien for 4 år siden. Dorit og Jan, I har en lignende historie fra 2. verdenskrig.
Jeg har prøvet at være flygtning, og jeg vil aldrig glemme det. Det har betydet usigeligt meget.
Det var din oldefar, der risikerede.
It's easy to mind your own business. It takes a little more effort to mind the community. But doesn't the feeling of having something in common, something that connects us, make it all worthwhile? TV2, all that we share.
I'm not sure, like the laptop holders is the ATMs.
No, laptop is really actually like that.
Yes, I don't know what that is.
Yeah, like what they are there, so that's why I found out on YouTube locally. That's some project work.
It takes clearer. It takes clearer picking up coming.
Yeah.
So that's by changing it to input 1. Remember?
Oh, clear on.
Yeah.
Yeah.
You
So
just
that's,
listen.
oh, it
Or
should
have
be.
you changed that?
It's no, it's in clear. It's because it's all third one and it's not.
Oh, the first day that we signed up for Monday.com, our department was already able to.
It's just do this. Yeah, it's in there.
If it is a little bit wild, get one of these microphones on, and that's more sort of stream. But it should be good enough just to That's how it's so just with the year, sort of straightforward. That one's straightforward. That one's forward. It doesn't work the first one, but it just means it's not safe. That's right, twice. And then you'll go. Don't do that, you know, let's start pressing a bunch of times. Only it was with the slide, but it's, you can't unfortunately see it on the screen. That happens on the screen. So it's just if you like, you can get a shape like you have.
Hi.
I'll be close by, don't worry.
Quiz, you're a sole trader. I bet you love your control, freedom, tax. Oh, you hate tax? Fair enough. Maybe it's not your thing.
Here, here. You are that nice.
in there, get some coffee, we'll have morning tea, little goodies coming out in our break. If anyone is wondering how to use the machines over there, just give myself or Dylan a yell. There's a button for hot water, a button for coffee. I think all four of them work that way, but they all work a little bit differently to do complicated things. Today, very similar setup to yesterday, so we've got our two presentations. We've got some great photos to show you all between the two. Please make sure you've got your cheers ready for that one. We've got a voucher for Experience Everything with Queenstown, and we've got a few t-shirts to give away. Tomorrow is my favourite day of the conference. It's a prize bonanza. So if you get to submit any photos, today's the day to submit them, because they'll be shown tomorrow and pretty much everyone will get a prize. So yeah, get excited. Prize bonanza Thursday is coming soon. I think that's all from me for now. So let's give a lovely big round of applause for our first presenter, Amanda. Thank you, Amanda.
Morning everyone, my name is Amanda Abbass. I am one of the lecturers at Monash University in Melbourne. I'm also an advanced life support paramedic with Ambulance Victoria, and today I'm going to be speaking to you about my research on compassion training and its impact on burnout and resilience, particularly in paramedics but across all healthcare fields as well. So I've been a paramedic for a number of years now, it's been about 7 years or so. It wasn't too long ago that it was my first day or first month at work, and I remember it like it was yesterday. And I distinctly remember working with a partner who was really pivotal in the rest of my career. She was incredibly warm, compassionate, approachable, and had a lot of the qualities that I very much admired in a person. And I remember we were a few months into my graduate year. I was walking up to a job with her. We were going to government housing in Melbourne, which, like everywhere else, there's plenty of. And I sort of let out a little bit of a huff, and she caught on to that pretty quickly. We had been to this particular patient probably 3 or 4 times in the last week, a frequent presenter for a very frequently not required problem, as you might say, and I was a little bit frustrated. And she sort of stopped me before I walked into the door and she said, Amanda, I can see your frustration, but just think about it from a different perspective. At the end of today, when you finish, you'll clock off. You'll go home to your warm bed, your partner, your dogs who love you. This is what this person is looking forward to in their days, to have someone come, keep them company for a little while. And it really made me zoom out of my privileged little bubble for a second, and I thought, I've sort of seen this all wrong. And I kind of just wanted to frame that to you when I talk about compassion today, because I don't mean rocking up to a house at 4 o'clock in the morning for a stub toe and being really excited to do that. I don't mean being unrealistic in our expectations about the things and the patients that we see, but it's about your time and enriching your time, which a lot of is spent at work, and considering that compassion can help us to do so. So, there are many reasons why we may be experiencing burnout in the job. It might be from ramping, overtime, shift work, working endless hours, missing important events. I'm sure it's things that we've all been through before. And the idea of compassion training, like I mentioned before, isn't to pretend like all of that doesn't exist at all, but it's aimed to arm healthcare workers with the tools to really protect themselves from something called empathic distress, which I'll speak about later. As I know, a lot of the points that I mentioned before are our everyday reality of the things that we face. We all want to lead our day from a place of positivity and compassion, but when burnout starts to poison every single interaction we have with our partner, our colleagues, our students that we work with, it's really difficult because it starts to really seep into our psyche and become a part of who we are and our professional identity as well. And as paramedics and healthcare workers as well, we struggle to separate ourselves, the AMBO, and ourselves, the person, because a lot of the magic that we have in our job is actually helping people as people ourselves. So that can be a really challenging thing for us. But we can't identify the issues that we have if we don't identify the soup that we're swimming in first. So for today, we'll think about our patients, but not too much. They're not our primary focus. Let's think about you, your colleagues, your family, your friends, your own professional identity. That's going to be our focus for today. I apologise in advance, I'm probably going to accidentally click something that's not supposed to be up there, but I'm going to show you a video that's going to help to define some of the terms we're going to speak about.
Writing is everything. Is the perspective in a significant way. If I'm
So what is empathy, and why is it very different than sympathy? Empathy fuels connection, sympathy drives disconnection. Empathy, it's very interesting. Teresa Wiseman is a nursing scholar who studied professions, very diverse professions where empathy is relevant, and came up with 4 qualities of empathy. Perspective taking, the ability to take the perspective of another person or recognize their perspective as their truth. Staying out of judgment, not easy when you enjoy it as much as most of us do. Recognizing emotion in other people and then communicating that. Empathy is feeling with people. And to me, I always think of empathy as this kind of sacred space when someone's kind of in a deep hole and they shout out from the bottom and they say, I'm stuck, it's dark, I'm overwhelmed. And then we look and we say, hey, I'm down. I know what it's like down here. And you're not alone. Sympathy is, ooh, it's bad, no. You want a sandwich? Empathy is a choice, and it's a vulnerable choice, because in order to connect with you, I have to connect with something in myself that knows that feeling. Rarely, if ever, does an empathic response begin with at least. I have it, yeah. And we do it all the time. Because you know what? Someone just shared something with us that's incredibly painful, and we're trying to silver lining it. I don't think that's a verb, but I'm using it as one. We're trying to put the silver lining around it. So, I had a miscarriage. Oh, at least you know you can get pregnant. I think my marriage is falling apart. At least you have a marriage. John's getting kicked out of school. At least Sarah is an A student. But one of the things we do sometimes in the face of very difficult conversations is we try to make things better. If I share something with you that's very difficult, I'd rather you say, I don't even know what to say right now, I'm just so glad you told me. Because the truth is, rarely can a response make something better. What makes something better is connection.
So, the video that you just watched is a really beautiful representation of the subtle differences between sympathy and empathy, where, simplistically put, sympathy is feeling for someone or feeling sorry for them, whereas empathy is about really feeling with somebody. Experienced healthcare workers know that too much empathy can actually be a bad thing though, and this can lead to what we call empathic distress. And this is where we invest ourselves too heavily in the emotions, oftentimes the pain and the suffering of other people, and we take it on, instead of being like one objective step back, which we would be in a healthy space. Empathy is very, very important. It's a beautiful feeling of shared human connection, but for healthcare workers who are exposed to high levels of trauma on a regular basis, overexposure can then do the opposite of what we all set out to do in the first place when we started our jobs, which is to not care at all. Not only now is this going to be at the detriment to the quality of the care that we deliver to our patients, but significantly detrimental to our own mental health as well. When a lot of us tie our own self-worth and our personal identity to our role as a helper to other people, when we stop feeling it all, this can have a really, really negative impact. And this is where compassion enters. So compassion is defined as a concerned response to another person's suffering, combined with the desire to alleviate that suffering. Compassion is more complex than a basic human emotion. It involves empathy, plus the motivation to take action to alleviate pain from others. Compassion is action-orientated and solution-focused, and it can shift our attitudes towards inevitably sad or painful circumstances to try and form connection. And this can be a protective mechanism to people, and it can also stimulate the brain's reward centres. I'm going to show you a video from the course's creator. This is Dr. Debbie Ling speaking a little bit about the course, what it has to offer and what it's about.
I'm Dr. Debbie Ling. I'm a compassion researcher at Monash University. I'm just going to talk briefly about the Monash Compassion Training for Healthcare Workers course, self-paced online, and just why there's so much interest now in compassion training. And largely that's around helping healthcare workers protect themselves from empathic distress. So I'm just going to share my screen. I've got a short PowerPoint that I'll just talk through. So compassion, the definition of it is that it's a feeling of concern for the suffering of another that's associated with the motivation to help. And there's actually been quite a lot of research in compassion in the last 20 years, but it does take a bit of time to filter into health professions education and training. There's been quite a lot of research over the last 30, 35 years on the difference between compassion and empathy, but it's really only since functional MRI technologies come out that researchers could show experimentally that they're different. This is one of the main papers that's created a lot of interest, and this was a functional MRI study where people were put in the scanner, showed videos of people who were distressed and suffering, and initially they were given the empathy instruction, just feel what the other person's feeling. And the researchers saw that it was triggering the pain response in the observer. So we know now if you're watching someone else who's distressed or suffering, you're trying to feel with them, it will trigger the pain networks in your own brain. Whereas when the observers were told to just have compassion, so remembering with compassion, you already know the other's suffering. You're not trying to feel their suffering. And you're thinking about how to alleviate their suffering. It's a different brain network. It's shown to protect against empathic distress, and it's a positive neural pathway in its own right, associated with feelings of warmth, concern, reward, and affiliation. So there's a big push now to help healthcare workers understand the difference between compassion and empathic distress. So compassion is focused on the other, it's good for the giver, makes the giver want to approach the other and try to help, whereas empathic distress is accidental, but it's self-focused, it's distressing to feel that, makes the worker want to get away from the other. So the term compassion fatigue is now considered to be a misnomer. It's actually empathic distress fatigue. This is an example, it's actually in the short course. We've got a lot of sort of diagrams to try and make it simple. So when we're confronted with the suffering of another, if we go into empathic distress or avoidance, they're lose-lose propositions for the worker. Bad for the worker and it's not good for the patient, whereas compassion is win-win, positive state of mind for the worker, and it also promotes a pro-social approach. So technically compassion is focused on what's the most constructive thing I can do for the other person at this moment. Keep in mind, compassion and empathy are not the same. Empathy is feeling-oriented, compassion is action-oriented. In the training, we help workers heighten their awareness of the self-other distinction. If workers accidentally go into empathic distress, it's considered that they've picked up on the distressing feelings of the other through emotion contagion, and you don't want that to happen. It's not good for the worker. Common questions you get asked about compassion. What's the ideal compassionate response? There is no one-size-fits-all, it's situation-specific. Depends on the need of the other and the skills and resources available to the helper. What about when I can't prevent the other person's suffering? This does happen at times, and we have to be realistic, but the worker cultivating compassion, it's still better for the worker to cultivate that than to cultivate empathic distress or feel helpless or hopeless. If there's no instrumental action you can do to alleviate the other's suffering, then compassion may just be present to the other, listening, supportive. There's lots of misconceptions about compassion. People think it takes more time. Technically, that's not correct. You can still, if you've only got 5 minutes or 1 minute or however long you've got for the person, technically you can still be compassionate in that time, and it's better to go into compassion in that time where you're solution focused than go into empathic distress. So just briefly about the course, it's designed for busy healthcare workers. I've had over 400 workers go through it this year, lots of bulk enrolments. The content in many ways has been market tested over the last few years because we were getting lots of requests for the compassion training over the last few years, and there's not many courses that are evidence-based that are set up. And it's designed for busy workers. If you don't have much time, we've got the key strategies there. You can download them off in summary PDFs. If you've got more time, we've got a lot of good resources on it, discussion forums, and we talk about some of the barriers to compassion as well. There's lots of good reasons why workers mightn't get there, whether it's time-critical demands, distracted, judgment of the other arising, and we talk about strategies, how to overcome that. So I think I'll stop there, and hopefully some of you will have time to do the course and let us know what you think about it. Okay, thank you.
Lovely. So the course was developed from the Department of Social Work and Psychology at Monash University, and 368 participants were taken through a 4-week training program where compassion was reinforced as the foundation of healthcare as part of this. Participants opted in willingly, and the training focused on uncovering what compassion is and what it is not. They learnt about the 3 C's, which are care, compassion, and connection. They were shown the latest research on compassion, demonstrating how it can benefit both the healthcare worker and the patient as well. They learnt about the differences between empathy and compassion and how they can transform the former into the latter. And participants were able to interact with others in the field as well as other people like their mentors to share their experiences. Part of the training program included exercises to heighten awareness of our actions on others and being on the receiving end of help as well. An example of this was the story of Annie Lennox and Dave Stewart from the Eurythmics. Dave Stewart spoke in 2020 about being grateful to a bank manager who gave the band a loan in the late 1980s. At this point, the Eurythmics were struggling, they had no income, they had no real commercial success at all, and the loan enabled them to produce their first hit record, which catapulted them onto the world stage with a song called Sweet Dreams. 40 years later, Stewart recalled in an interview how pivotal the belief of one person was who gave him an opportunity. His words were, "Remember those who helped you along the way." Participants, as part of the compassion training course, partook in their own form of this exercise, where they were encouraged to reflect and speak to each other about people who helped them along the way as a gratitude reflection. So the paramedic training program, or the compassion training program, was piloted on paramedics within Ambulance Victoria. It investigated the impacts of burnout, resilience and compassion on paramedics. And examples of the following design measures are 4, 5 and 7-point measures from strongly disagree to strongly agree, as well as not true of me at all and very true of me. What we found, this study was also a collaboration with the Wellbeing and Support Department at Ambulance Victoria, and that was who marketed it to paramedics. Of the 368 members who enrolled in the course, 158 completed a repeated measure retrospective pre-post design survey on their experiences, and it was found that the average participant had been a paramedic with Ambulance Victoria for about 10 years. 9 participants were also interviewed one-on-one, where we were able to delve deeper into their individual responses and their experiences. So what did we actually find? We found that there was an improvement in mean score in compassion on a number of items, and there was a decrease in disengagement on the burnout inventory. When honing in on this, participants deduced that that was actually a positive thing, as the compassion training had allowed them to disengage appropriately as a means to then drive action when they found the onset of empathic distress. This in turn would reward the participant as well as the giver. Some qualitative comments that we found When participants were asked, did the course provide you with strategies to cultivate compassion, protect yourself from empathic distress, and strengthen common humanity on a daily basis? One participant said the practice of reflection was especially beneficial. When asked, do you feel that this course taught you applicable skills in maintaining compassion rather than entering into empathic distress? A participant agreed that it did, and they found it to be quite enlightening. When asked, do you think it's useful for paramedics to share their experiences? One participant said yes, that that's helped bring about light bulb moments for them and normalise new knowledge and concepts on compassion. If you would like more information on the compassion training course, this is a link that's not very useful to you, but you can Google what's underlined there and that will come up with Monash University. There's a number of courses running throughout the year. Like I mentioned as I've been speaking, I had nothing to do with the actual creation of this course. I'm researching the benefits of this course, which has been found to be really positive so far. You can also contact Dr. Debbie Ling, who spoke just before, who was one of the creators on this course, and she is able to give you more information as well, if you like. So, what we concluded. To the best of our knowledge, this is the first attempt at reporting compassion training results for staff at a large ambulance service in Australia. These pilot studies are really important for the paramedic discipline and the understanding of compassion training and education. Whilst I'm sure that we can all agree that being more compassionate is a really positive thing, this study aims to validate compassion training program as a really valuable tool in promoting a positive state of mind in participants and in turn patients as well. And before we end today, I'd just like to leave you with one more video. I think this really encapsulates a lot of the themes of the course, namely compassion and connection, so I hope you enjoy it.
It's someone you've been gaming with for years, but
I didn't do what you said. But that's so close.
it's someone you've been gaming with for years. They just don't know it yet. In a minute, we'll show them that they have more in common than they think.
Hej alle sammen. Tak fordi I kom. Thomas, vil du stille dig der? Og Aske? Thomas, du bor med din familie i et dejligt hus på Vinkelhøj 8 i Viby. Før I flyttede ind, var det faktisk dit barndomshjem, Aske.
Det er rigtigt. Ja. Fodbold i haven om sommeren og i forstående. Ja, præcis. Vi laver igen.
Mathilde, vil du komme her? Hej. I to har faktisk stået over for hinanden før.
Okay.
Da var I 12 år. Og det var en rugbykamp.
Okay, ja.
Kampen endte i øvrigt 42-0 til Askesov.
Tak for kampen.
Inger. Mathilde, den nat, du kom til verden for 27 år siden på Christiania, var Inger det første menneske, du så.
Var du min jord? Nå, kan du huske det?
Anna, i 2012 er din mand ude at løbe en tur. Pludselig falder han om med hjertestop. Heldigvis er der en, der reagerer hurtigt og redder ham. Knud, Vil du komme her?
Just below the surface, a total stranger can turn out to be someone you're actually connected to. Someone who rouses forgotten memories. Like the very first kiss. Someone who reminds you that you're not alone. But that somebody else also has a bulldog named Prebbie. Someone like Thomas, who put out a fire at Vivica's place. Someone you've been gaming with for years, but have never met.
Gentlemen, milk, little salt.
Det er løgn. Men så frækker, jeg var fandme kendt anden i, så 4 år, der var sådan mødt anden og set anden før.
If we approach each other, we might find out that we share the same destiny.
Rane og Maha, I kom til Danmark fra Syrien for 4 år siden. Dorit og Jan, I har en lignende historie fra 2. verdenskrig.
Jeg har prøvet at være flygtning, og jeg vil aldrig glemme det. Det har betydet usigeligt meget.
Og Rikke? Det var din oldefar, der risikerede sit liv ved at sejle Jan over Øresund den oktoberaften i 1943.
It's easy to mind your own business. It takes a little more effort to mind the community. But doesn't the feeling of having something in common, something that connects us, make it all worthwhile? TV2, all that we share.
Thank you so much.
That was brilliant, thanks Amanda. Does anyone have any questions for Amanda? Ooh, that was a quick hand, that was a whiplash.
So, great questions. I'll try and remember them all. It was done in April of this year, and it was both on-road and off-road staff. So it was marketed from the Wellbeing and Support team to everyone in Ambulance Victoria. I'm not sure exactly who it reached and who it didn't. I know emails are a little bit dicey in terms of how we're allowed to send them out. Amazing, yeah. I had also never heard about it before. By the time I got around to researching it, I believe some team managers were distributed the information and distributed it to their teams. So some people missed it, some people didn't. In the end, 368 ended up signing up. And it just happened to be a 10-year average for the people who did sign up. Yeah. Any questions that I missed? No.
Any further questions at all? Let's okay with Amanda. I might share the links that you had up there in the email that goes out at the end of the week. So if anyone would like any more information, yeah, it seems like a great program and there's just scratching the surface there, I'm sure. So let's hear it one more time for Amanda. So we've got a couple minutes up our sleeve, so I'm going to really mix things up a bit and we're going to go Instagram photo competition now. So warm up your vocal cords because hopefully this works and we're going to get straight into it. And let's see how we go. So we have probably about, I think, 8 or 9 photos to show. Remember, loudest cheer gets the main prize. We then have a number of other prizes that we'll be giving away. So a $100 experience everything Queenstown voucher and then a number of t-shirts. If your photo is showing up here today, please see Jill and myself. We also have a bunch of ski method gear, goggle wipes and whatnot that we can give. So, first photo. What do we reckon? 3 people like that one, nice. Next one. Oh, yeah, I think let's take a little bit to warm up this morning. clear where they're well done to put that one together. That's impressive. So yeah, we've got the winner there with the video, and then I'm going to say the mannequin and then the skiing tax-free, I think, is the other winner. So let's hear it for everyone who submitted a photo today. We will take about a 10-minute break again. So please, yeah, fill your plates up, grab a cuppa, and we'll get going again probably about 8:30.
is electrical. I've been told y'all this is cinema. I am on my Kubrick horn like a Spielberg, close to kind of fall. Feeling awesome to be back, and I'm working all competition. Making what I wanna, that's a flex. Can't do what you want, I ain't that a bitch. Slow up when no one is your gun. Magic, I'm feeling my palms. Make them go down with them hums. Nah, I ain't riding no waves. Too busy making my own waves, baby. I ain't riding no waves. Too busy making my own waves, baby. I ain't riding no waves. Too busy making my own waves, baby. I ain't riding no waves. Too busy making my own waves, baby. Surfing on my own wave, baby. Surfing on my own wave, baby. Surfing on my own wave, baby. Surfing on my own wave. The industry's so full of shit. Welcome y'all to the enema. Nah, man, no subliminal. Cause they're insecure, they know who they are. Feeling awesome to be black. And I'm working all competition. Everything that I do is a flex. If you don't get me, not my issue, bitch. Slow up, but no one to shogun. Got the magic in my palms. Make them go dumb with them hums. Nah, I ain't riding no waves. Too busy making my own waves, baby. I ain't riding no waves. Too busy making my own waves, baby. I ain't riding no waves.
Okay guys, a couple more minutes if you want to fill up your plate. There's plenty of food here, and then we'll get started.
Surfing on my own wave, baby. Surfing on my own wave, baby. Surfing on my own wave, baby. Surfing on my own wave.
Alrighty, so we're pretty much going to jump straight into the next session. So once everyone's sorted, please, whilst David is talking, feel free to help yourself to more food or drink. There is plenty there, so don't be shy. And also, I forgot to say hi to everyone on the live stream. So we do have these sessions being recorded, so if anyone would like to watch back anything that has been talked about either yesterday or any of our future sessions, the links are being sent out daily because they're always changing, but keep an eye on that, and we'll do a summary at the end of the week if you want to look back at anything that may have been covered. But yeah, you're not here to hear me talk, so let's hear it for David. Come on up.
Good morning, everyone. My name's David. I'm one of the General Surgical Registrars in Queensland Health. Today I'll be covering general surgical emergencies. Hopefully a refresher for all of you here today, and then provide some insight into what happens in the operating theatre. So I kind of dedicated this talk to the good, the bad and the ugly. The good's kind of out of the option, just because that's what we get to do as clinicians, look after patients and operate. But today it's really talking about the bad and the ugly presentations that we should all be aware of. So today I'll be talking about quite a few things. We'll be talking about appendicitis, cholecystitis, gut obstruction, lower gastrointestinal bleeds, perforated hollow viscus, ischemic gut, and it wouldn't be an emergency care conference without trauma. So to begin with, a little bit of background. So whenever a patient presents, there's obviously a dynamic process, but what we're trying to filter through is, does this patient have an acute surgical abdomen that requires urgent intervention? And there's lots of definitions. This is probably the biggest consensus statement, that the acute abdomen can be defined as abdominal pain from a non-traumatic origin within 5 days. We'll also be covering trauma today. Essentially, this can range from, a wide list of differential diagnoses, some that are benign, self-limiting, you could let them be and they'll go away with no harm to the patient, whereas others require urgent surgical intervention that can be life-saving. So I quite like this as a roadmap, one, because I like London, and two, because I think it's got a good differential diagnosis list. This was kind of designed by a UK radiology doctor that kind of talks about the surgical sieve, or looking at the differentials and pathways for patients coming in with an acute abdomen. So it's actually quite a handy roadmap that then separates different organ systems that you can then filter through, with, of course, the highlight of the red, which is things not to be missed. So let's get into it. Hopefully this can be a bit interactive. So can someone tell me what's going on here? Appendix, yeah. So this is acute suppurative appendicitis. You can see here the vermiform appendix here that's injected, and there's some purulent fluid in the right iliac fossa. This is at the point where, longer time would then lead to gangrene and perforation, making it a complicated appendicitis. So, refreshing about appendix, let's just talk about the normal. So, vermiform appendix comes from the Latin meaning worm-like and to hang upon, and that's because it arises from the posterior medial aspect of the cecum, or start of the large bowel, and it can be quite variable in length from 2 centimetres to 20 centimetres. The most common length is approximately 7 centimetres, and it has a variable position in the abdomen. And this can lead to different presentations of pain, especially in the pregnant patient with a gravid uterus that can push the appendix into the right upper quadrant, where you can sometimes think, is this preeclampsia? But it could be appendicitis, which is the most common non-obstetric surgical emergency in pregnancy. The other positions are important surgically because sometimes it can be tricky to find, so you've got to, kind of manipulate the bowel to get to it. So how do these patients present? It's pretty typical, and what I try and tell people is that even if it's atypical, common presentations are more common than rare presentations. So, appendicitis affects about 200 people per 100,000. And so it's a common presentation. So the classical history is you'll hear patients present with some generalised abdominal discomfort, usually in the periumbilical region, but then they have this classic migratory pain down to the right iliac fossa. It's often associated with nausea, vomiting, anorexia, and fevers. Some tips is that when patients present with a classical history but the pain's been present for more than 5 days, you always need to think about, is this going to be a complicated appendicitis? So is there going to be a phlegmon or abscess formation, in which case we manage these patients differently. So I always refer to the Alvarado scoring system. This is a scoring system that's been validated in the literature. That's an easy way to think of the typical things that you get with appendicitis, and you add them up to get a score, and essentially the higher the score, the more likely that the patient has appendicitis. Because at the end of the day, appendicitis is a clinical diagnosis. However, with the advent of readily accessible imaging in Australia and New Zealand, we often get ultrasounds. Now, ultrasounds in females is mainly to look at the gynecological organs. I always try and tell people that. So it's not actually to diagnose the appendicitis, but it's actually to rule out ovarian pathology that can present with similar type symptoms. So I guess the next question is, when do you need to CT these patients? They're often young. The most common population is kids and young adults. So we want to be, thoughtful of this, because CTs are associated with radiation with long-term increased risk of intra-abdominal malignancy. So I always tell people some reasonable indications: pain more than 5 days, aged more than 40, and if you palpate their abdomen and they've got a mass in their right iliac fossa, you should all get a CT. And I'll talk about that in a moment. So I guess what's new in the literature, what's going on, is anything changing? Short answer, yes. Long answer, no. There's a trial being run out of Queensland at the moment that's finished enrolment that looked at, can you give antibiotics alone for patients, and can we avoid doing surgery on them? This is stemmed from the CODA trial that looked at non-operative management of acute uncomplicated appendicitis, and found that they were non-inferior, but the patients that had antibiotics alone had a 30% chance of getting recurrence. So if you tell a patient you've got a 30% chance of this pain and presentation coming back, most patients with appendicitis say definitely not. I'd rather proceed with an operation. And also with the advent of travel post-COVID, if you're travelling overseas, you don't want to be in a position where you're got appendicitis and need an operation in the middle of Sudan. So I always try and tell patients that if they're travellers. So in terms of what about complicated appendicitis? So this is when patients present, they've got 5 days, you're like, I can feel some big mass in their abdomen. These patients you want a CT. The reason being is that they are usually managed non-operatively. And what I mean by that is in the first instance, you want to settle them down with antibiotics, because if you go in there operatively, it's like a mess. It's a dog's breakfast. You end up causing more damage than good. You injure the bowel, they get a bowel leak. So unless they're truly septic with shock, you don't go in. And sometimes we can get our radiology colleagues to actually put a drain in there that drains it, and then we can do an interval appendicectomy. And the reason why we offer this interval appendicectomy is, could this be cancer? About 5% of cases of complicated appendicitis have an associated appendiceal neoplasm or tumour, especially patients older than 40, which I talked about before, which is why I like to get a CT on those patients. So a little bit about the data. So this is the CODA trial that talked about appendicitis with antibiotics alone versus surgery. And then this is one of my colleagues that's running a trial looking at antibiotics versus surgery in uncomplicated appendicitis. All right, moving forward, does anyone want to tell me what's going on here? It's a bit of a trick question. So this is a laparoscopic view, and one that I hate, when you enter the abdomen, and this is cholecystitis. So this is the omentum, all wrapped up in the gallbladder fossa, and we talk about this being an intraoperative view of the gallbladder of grade 4, i.e. you can't even see it. So there could be a dead gallbladder under here, which the omentum, or the policeman of the abdomen, wraps up over to protect the body. So why did patients survive perforated appendicitis 100 years ago? It's because of the omentum. So cholecystitis. So a couple of myths about the gallbladder that I always like to talk about is biliary colic or gallbladder pain is a misnomer. So it's not colicky abdominal pain, it's constant pain, okay? So patients with colicky abdominal pain is pain that comes and goes, and that relates to a hollow viscus that contracts and relaxes, okay? And so the pain comes on, goes away. But with biliary colic, it's constant pain, and it's often worked up as acute coronary syndrome. Why? Because it's often like a tight band in the lower chest, upper abdomen that radiates to the back, that's associated with nausea, vomiting, and the worst pain that they've ever imagined. Females often tell me that it's worse than labour pains, and so they request for their gallbladder to be removed as soon as possible. So in terms of cholecystitis is both like an inflammatory but also an infective process that I think of as happening after 24 hours of having biliary pain. And so when we did cultures of gallbladder specimens for acute cholecystitis, 40 to 70% roughly had positive bile cultures for bacteria. So who gets acute cholecystitis? Patients with gallstones, okay? So 90% of people with cholecystitis have gallstones. Now, there are rarer types, such as like if you're in Southeast Asia, you can have liver flukes cause it and things like that. And this other condition called acalculous cholecystitis, that's in ICU patients that have shock from other reasons, and they get this ischemic process of the gallbladder. But most people have stones here, and this is a photo of a CT scan with uncomplicated, so there's no cholecystitis, but gold standard is ultrasound. So what guidelines do we use? The biggest consensus statement is with the Tokyo 2018 guidelines. It's quite a good paper that's not too long, so if you want to have a read about biliary presentations like cholangitis, cholecystitis, I think it's great. So here you can see, to get the definition, you've got to meet 1A and 1 plus B and C. And so these are common things that you'll see when you have patients present to you. So what can you do? Well, surgery is the definitive management for symptomatic gallstone disease. Early is preferred than late. There was a traditional teaching when laparoscopic cholecystectomy came out in the late 80s, early 90s, that it was too dangerous. There was thought to be an increased risk of vascular biliary injuries, but that's not the case in large literature that's supported with early intervention. What else can you do? You can do antibiotics alone, and in some patients you may choose to do this. It may be because of comorbidities. It may be that they're on therapeutic anticoagulation like warfarin or Pixaban or rivaroxaban, or it may be that they're unfit for a general anaesthetic, or that's their advanced healthcare directive. In cases that are failing antibiotic therapy and that are really sick, we can get radiology to put a drain in it called a percutaneous cholecystostomy. Now, that can either be the end management of that patient, i.e. that they're left with a drain, or it can be a bridge to theatre in the patients that are just really, really sick but otherwise not too comorbid. Does anyone know what this is? No, not quite. This is a tricky one. This is a gallstone, and this is the bowel. This is the blood supply to the bowel, the mesentery. And this patient's presented with a gut obstruction from a gallstone that's eroded through their gallbladder into their bowel. Okay, so gallstone ileus. I thought I'd follow up on gallstones into that. So you can see why I like taking the gallbladder out, because it causes lots of problems. So I'm going to talk about gut obstruction, but I'm not going to talk about gallstone ileus. That's another talk. But I want to talk specifically about small bowel obstruction and adhesional type, okay? Because that's by far the most common. So a small bowel obstruction is the inability of the contents of the bowel to pass through a segment, okay? It's one of the most common surgical admissions that we have, and the majority arise from intra-abdominal adhesions that form in the majority of patients from previous abdominal surgery. There are other times where they haven't had surgery and have had some kind of infective or inflammatory process, but by far it's certainly surgery. I always tell people to be aware of the small bowel obstruction in the virgin abdomen. Now, the reason being is that they haven't had previous surgery, and so it's unlikely, unless they've got a history of some infective or inflammatory abdominal condition, to get them. And so they often are not going to pass conservative management. So early laparoscopy, you might find a congenital band adhesion causing it is important. So I guess for acute small bowel obstructions, the majority of these are settled with conservative management. So you can tell patients, look, the majority of you'll settle down without needing an operation, but obviously a small percent will need to do that. So how do these patients present? It's a classic colicky, gradual onset, worsening abdominal pain associated with nausea and vomiting, and that their bowels are not working. So they describe no wind, no bowel motions, which is a thing called obstipation. But the patients often have this episode where they have loose bowel motions just before the bowel obstruction, but then they become truly obstructed. And that's because the gut's trying to respond to an obstruction happening by causing rapid peristalsis. So who do you need to be aware of in terms of red flag presentations for these patients? It's patients who have severe constant pain or peritonitis on examination. These patients definitely need to go to theatre, as they'll not resolve. So what do we do next for conservative management? Well, they're going to get a nasogastric tube. We're going to keep them nil by mouth for bowel rest. And when they're decompressed, we're going to do a thing called a gastrographin trial. Now that's a contrast agent that you can give orally or via the nasogastric tube, and it's both diagnostic and therapeutic. So it's a hyperosmolar radiopaque solution, and it can draw the contents of the bowel to pass the gut obstruction, but it can also get us an abdominal film to see whether or not the contents have entered the large bowel, which means that they're resolving. So in this film here, unfortunately for this patient, they've got a failed gastrographin trial. So this is all stomach, small bowel, small bowel, small bowel, and this is the colon, and there's been no contrast that's entered the colon. And so this is highly predictive that this patient will fail conservative management and need surgery. And when to do it, usually 24 to 48 hours is when you need to do it. Any longer you risk, the bowel being compromised and them needing a gut resection. And similarly, it's very, distressing for the patient, so early intervention's key. Some patients who have a battle-scarred abdomen, not fit for an operation, you can consider putting in a PICC line and starting TPN to see if you can give them nutrition while they try and wait several days to weeks for it to resolve. So when to operate when you're concerned about ischemia, which is that constant severe pain, or peritonism, or if they've failed conservative management. Okay, let's talk about a lower GI bleed. Never forget the torrential upper GI bleed, especially in the alcoholics with cirrhosis with large varices. They can be pretty impressive. I'm sure you've seen them all. So this is kind of the meme for lower GI bleeds, to CTA or not to CTA. That literally happens all the time. They hate it. So a little bit about background. So what is a lower GI bleed? So it's a bleeding source of the gut that's distal to the ligament of Treitz. So that's at the DJ flexure. So proximal to that is upper GI bleed. The most common cause is your diverticular bleed, so outpouchings, the colon, very common in people over 50, about more than 50%. But other causes that you've got to always consider, especially in younger patients, is colitis, which can be mixed, inflammatory, infective, ischemic. Always think about, could this be cancer, hemorrhoids, but usually they will tell you that they've got like a lump on their bottom and it's bleeding. Benign tumours, and in old people, angiodysplasia or abnormal capillary beds that can be fragile and bleed easily. So in terms of some of the local data for me, it's about more than 5% of my clinical workload, so it's quite a lot of patients presenting with this. With everyone being on therapeutic anticoagulation for some reason or another, we certainly notice that. So more than 50% of patients are anticoagulated, and I haven't included aspirin, clopidogrel for antiplatelets because they're common as well. The most common patients I see are elderly and male, and here's some statistics from our institute. I guess the lower GI bleed's hard to kind of get good quality evidence for because it's so heterogeneous. The populations vary, the conditions are vary, centres vary with what they do. So we rely on expert consensus statements and pathways related to that large bodies have put out, like the British gastroenterology guidelines and things like that. So what they've told us so far is that lower GI bleed should be managed in centres with 24/7 availability for not just interventional radiology that can sometimes embolise, but also surgeons, because if that fails, they often need some form of a resection or colectomy. In terms of what's good in the early hospital setting is this Oakland scoring system, which was developed in the UK. Now, this is an easy online tool that you can use to see whether or not it's safe to send your patient home who's had a lower GI bleed. So that's a good reference point. So more about CTs, because I like them. I guess with increasing technology, we're getting better at being able to detect bleeds, and this is a special mono-E CT scan that is trying to see that on higher definition phases you can definitely see a bleed that then corresponds on the formal angiogram that they've done here. So here's some of the guidelines. Essentially it's whether or not the patient will need to be admitted for a scope, re-CT, surgery, or whether or not they can discharge. I guess the take-home point for today is, when do you actually get a CTA? Now, over-ordering of CTs is a problem, and certainly a CTA, which has an arterial phase, has a much higher contrast load to the patient. And so I tell people that unless they've got hemorrhage with instability, a CTA is a waste of time. Now, you may want a CT portal venous phase for other reasons, like you're worried about colitis, blah, 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 but you shouldn't order a CTA unless they've got instability, and that's because you won't see anything. So if we actually look at the detection rates, you've got to be bleeding more than 0.3 mils per minute on a CTA, or at formal angiogram more than 0.5 mils a minute, which is more than you think. And that's obviously a dynamic process. So if it's vasospastic or there's a clot on it at the time, you won't see anything. Okay, let's talk about the ugly. So you've been asked to attend a medical emergency call for a 60-year-old gentleman who's admitted to mental health. It's been called for sudden onset chest pain and abnormal vital signs. And the patient has a 3-day history of nausea and vomiting. So you arrive, what do you do first?
Check for danger.
Yeah. On mental health especially, but no, so you do your primary survey with yes, of course, check for danger. But this patient's got his own airway, it's patent. However, he is in respiratory distress. He's got a rest rate of 35. He's saturating only 86% on a non-rebreather. He's tachycardic without hypotension, and he's got new atrial fibrillation without ST changes. He's febrile and confused. So you get 2 large IV bore cannulas, you send off bloods, you resuscitate him with fluids, and you get him to the CT scanner. So I'll just play this video, see if anyone can tell me what's going on. Anyone got any ideas? See if I can go back. Where's my pointer? So this is badness. It's not working. Sorry. So I'll do it. See here, this is pneumomediastinum, or air in the mediastinum. You can see that it's quite throughout the mediastinum cavity. There's a large left-sided pleural effusion and a smaller right-sided pleural effusion. And in this context, this is highly suspicious of esophageal perforation. This is an endoscopy view showing a hole in the esophagus. So we'll talk about perforated hollow viscus, but specifically just wanted to talk about the esophagus because it can be quite a dramatic presentation that you'll see and won't forget. So when we talk about esophageal perforation, we always think about Boerhaave syndrome. So that's spontaneous rupture of the esophagus, or something that we talk about as Mackler's triad, which is vomiting, chest pain, and subcutaneous emphysema. So why do I have this old surgeon up here? So this guy's a bit of a legend. Norman Barrett, Australian-born British thoracic surgeon. Barrett's esophagus is dedicated after him. But he's the first surgeon to successfully repair a perforated esophagus that survived in 1947, I believe. And so he's got other names and interests after him, but I thought that's quite interesting. So in terms of why is esophageal perforation so high risk, is that it's usually the thoracic esophagus that perforates, not the intra-abdominal. That leads to mediastinitis, which has a high morbidity and mortality rate, up to like 30 to 50%, because you're essentially got pus all throughout your heart and lungs. So the majority of these patients are managed with surgery. How that's done, it depends. Sometimes you can try and go laparoscopically through the abdomen, open the hiatus, bring the esophagus down, stitch it, put drains in the chest, but often you need to just crack the chest with a thoracotomy to wash it out and put large drains. Someone got this right before, over in that corner. What's this photo? Well, but yeah, not colitis, but ischemic gut. So you can see here distinctly, there's a demarcation here of healthy bowel and hemorrhagic non-viable bowel. And so you can see here, so this was a virgin abdomen and he had a mid-gut volvulus. So ischemic gut, also a pretty impressive kind of presentation. It's also called mesenteric ischemia. In terms of what actually causes it, it's some form of blood flow impairment, whether that's arterial or venous, or embolus or thrombus. It depends. I always tell people time is gut, so earlier interventions associated with kind of better outcomes. So if you don't need to resect non-viable bowel, the patient has a better outcome, especially if it's large amounts of small bowel, because then you can get short gut syndrome. So this patient in the photo, he presented quite late because he thought he had gastro, so just something to be aware of. In terms of what surgeons really care about is their actual pain levels and examination, not their lactate, which is commonly misconstrued. So if a patient has constant severe pain or peritonitis, or the patient's requiring high-dose opioids pre-hospitally or in ED, I'm thinking this patient needs to go to surgery, and more common than not they do, and they have ischemic gut. So in terms of going back to CT again, CTA or arterial phase is the gold standard operation. Here you can see an embolus in the superior mesenteric artery, outlined on the left on the normal view sagittally, and then the reconstruction view sagittal too. So what are your options? It kind of depends what it is, where embolus, thrombus, or whether it's venous. You can sometimes do thrombolysis, sometimes you can go endovascularly with our vascular colleagues, or there's the open approach where you can aim to re-establish the blood supply, however way you want to do that, with your backup bailout option doing a bypass, and obviously the non-viable bowel needs to be resected. All right, guys, last but not least, trauma. So I think, just to make it simple and not too convoluted, I'll be talking about penetrating abdominal injuries, which in Australia and New Zealand, the most common is going to be like stabbings, as opposed to in America, gunshot wounds. So trauma, so penetrating abdominal injuries are uncommon, and represent less than 3% of presentations for trauma in Australia and New Zealand. Obviously, we've talked about region variability. So, if you're working in Texas or Cape Town, you've got different trauma than you do here. So a little bit of a background which is quite interesting is that back in World War I, where soldiers were getting shot all the time, with the advent of general anaesthetic and safe operating conditions, surgeons found that patients who underwent a trauma laparotomy or slot of the abdomen had better outcomes than those that were managed conservatively, where you just hope for the best, keep your fingers crossed, which, obviously makes sense. In that era, trauma laparotomy became the gold standard for management of penetrating abdominal injuries. So when we talk about penetrating abdominal injuries, you've got to think outside the box. You've got to think front, chest and back, because sometimes patients will come in with anterior stab wounds, but they've been stabbed in the back quite high and they've actually got a thoracic injury that you need to assess, and that's why you've got to manage patients in accordance to the principles of EMST, or early management of severe trauma, because if the patient's breathing is not, responding, you need to think about, is there something else? And you'll look to the back, find a chest injury, and need to put an intercostal catheter for a pneumothorax. Obviously the flanks are important, as well as the back for retroperitoneal injuries that affect other organs like the colon, kidney, ureters. So in terms of management, I always say that upper abdominal injuries, you need to be suspicious for cardiac or thoracic injuries, especially the diaphragm. In terms of the cardiac, that's kind of, if it's close to the Ziffy sternum, you've got to be really suspicious. This is actually a diagram that's from the Trauma Centre in Auckland here in New Zealand that has good guidelines that you can check flowcharts on about when you need to go to theatre. In principles, the management of penetrating abdominal injuries, if they need to go straight to theatre, include patients that are hemodynamically unstable, patients with generalised peritonitis. If the instrument or foreign bodies breach the peritoneum or retroperitoneum, and that can be either established by a physical exam, whether you do a local wound exploration, or on a CT scan. If there's impalement, evisceration, those are other indications. So I guess the other take-home message is, if a patient presents with the foreign body or object still in situ, don't remove it. It can be causing a tamponade effect that when you pull it out, they can get massive hemorrhage. Anterior abdominal stab injuries are quite interesting in high volume centres, so patients who do not meet this criteria above. Some centres watch and wait, and that's because they're usually in developing countries without the resources, and they've shown that it is safe as long as you've got the option to take them to theatre later if they develop any of these, like, instability or peritonitis. And then I guess lastly, what is the role for laparoscopy or keyhole? So not doing the big cut, which is associated with a lot of morbidity for the patient, especially if it's negative. We sometimes just put a scope in. Now, negative laparoscopy rates are slightly higher, obviously, because you're just having a keyhole view, but in the selected patient population, this is certainly on the rise in Australia and New Zealand. The US still pretty proud laparotomy centres. So now for some photos. So this is emergency thoracotomy for a stabbing. What you can see here is that the lung's been retracted, the pericardium has been opened, and there's been a penetrating injury to the left ventricle, which you can't see in that photo or video, but that's been stitched closed. And this was a classic thoraco-abdominal injury where we had to explore for a diaphragm injury as well. Does anyone want to have a crack at what's going on here? Yeah, shotgun. Does anyone know what this type of imaging is? Yeah. So it's a fluoroscopy, or it's actually a cholangiogram. So gunshot close range to the abdomen. These are all the pellets. This isn't working, sorry. But here you can see here, the patient actually has a penetrating biliary tree injury. So this is contrast going out of the bile ducts in the liver because a pellet has actually penetrated through there. It's very rare, but something that you can see. So that's it for today. Thanks, Quinton and Dylan, for having me. Did anyone have any questions?
Anyone brave enough to ask one? Thank you. All right, let's hear it for David. So thank you very much, David, for giving us an insight in terms of what actually happens in the operating room once we turf the patients your way. So that concludes our two, interactive sessions for today. Can we have one more round of applause for both Amanda and David? So tomorrow we're back to the afternoon session, just to keep you guys on your toes. So we will be kicking things off here at 4:30. So 4:30 start time tomorrow. For those attending the wine tour today, it's a 10:50 that the buses will leave, and we're just meeting at the QT reception, so that's 30 Brunswick Street. So not the Ridges one, the QT reception just behind us here. For those hanging around for Scott and Alex's talk, so today they've sort of got the next level up from their talk yesterday. So they're looking in terms of like, you've got wealth, what to do and how to expand your wealth. So things like self-managed super, using equity in your house, how much money should you be putting away in super, where should you be putting your money, I guess. And they'll also have a bit of a case study there for anyone who's interested in hanging around for that one. And there's lots of food left, so please fill up your pockets, your bags, enjoy the day, and we'll see you here tomorrow at 4:30. All right, cheers guys.
What I would do to take away this fear of being loved, allegiance to the pain. Now I fucked up and I'm missing you. I'll never be like you. I would give anything to change this fickle-minded heart that loves fake shiny things. Now I fucked up and I'm missing you. I'll never be like you. I'm only human, can't you see? I made a mistake. Please just look me in my face. Tell me everything's okay, 'cause I got it. Ooh, I'll never be like you. I'm only human, can't you see? I made a mistake. Please just look me in my face. Tell me everything's okay, 'cause I got it. Ooh, I'll never be like you. How do I make you wanna stay? Hate sleeping on my own, missing the way you taste. Now I'm fucked up and I'm missing you. I'll never be like you. Stop looking at me with those eyes, like I could disappear and you wouldn't care why. Now I'm fucked up and I'm missing you. I'll never be like you. I'm only human, can't you see? I made a mistake. Please just look me in my face. Tell me everything's okay, 'cause I got it. Ooh, I'll never be like you. I'm only human, can't you see? I made a mistake. Please just look me in my face. Tell me everything's okay, 'cause I got it. Ooh, I'll never be like you. I'm falling on my knees, forgive me, I'm a fucking fool. I'm begging, darling, please absolve me of my sins, won't you? Oh, I'm falling on my knees, forgive me, I'm a fucking fool. I'm begging, darling, please absolve me of my sins, won't you? I'm only human, can't you see? I made a mistake. Please just look me in my face. Tell me everything's okay, 'cause I got it. Ooh, I'll never be like you. I'm only human, can't you see? I made a mistake. Please just look me in my face. Tell me everything's okay, 'cause I got it. Ooh, I'll never be like you. Walking with a game on, you are my kind, classic mind, and you look so fine. Loving the cold, smoke and roll, see your fingers shake. and getting through your heartbreak. Some kind of free, safe for me, don't know what I need. Don't doubt me, babe, you make me wanna change. Break my bed to make me wanna stay. I can't bite me, babe, you make me love the pain. Break my bed to make me wanna stay. I can't. When you say it like that, got me falling right back. When you say it like that, let me fuck you right back. Get in the door, silent walk. Who's the first to speak? Speaking like a real freak. Voice in my head, in my bed, filled with you instead. Taking your time, work my mind, and then play with you. And play pretend it's all true. Follow me down, listen round to that deep dark sound. Don't doubt me, babe, you make me wanna change. Break my bed to make me wanna
just a heads up, Scott and Alex will be talking on the microphone. It's just for live streaming, not so, yeah, they're shouting at all of you guys. But yeah, thanks for hanging around, and I'll hand it over to Alex, it looks like.
Yep, thanks, Quinn. Good morning, everybody. Sorry we were a little bit late, so we'll be jumping straight into it. So for those of you that came last night, we ran more of a beginner session, so today will be a little bit more advanced than what we were talking about last night. If there's anything, though, that we are talking about that you don't understand or any terminology that we're using, just pop your hand up. No such thing as a silly question. We want to make sure you guys get value and you learn something this morning as we're taking you through this more sort of advanced session today. So some of the things we'll be talking about will be self-managed super funds, taking you through what's called debt recycling, so that sort of strategy, how to use equity in an existing property to potentially build your property portfolio, running through a case study, and talking a little bit more about super contributions as well. So before we jump into it, though, similar to last night, worked. There we go. Yeah, just a disclaimer, so it's all general advice today, so we don't know your own personal circumstances, so just take everything we say with a pinch of salt, basically. Okay, yeah, as I sort of mentioned before, this is typically what we're gonna run through this morning, these 5 topics. So self-managed super funds, using equity in your property, debt recycling, why you would put more money into super, and we'll be running through a case study, which is basically taking you through the differences between investing money versus paying off debt versus putting extra money into super, and sort of the pros and cons of that and how that sort of works out as well. We'll start by taking you through using equity in a property, though. So for those of you that were here last night, I think a lot of you had a house. Can I just get maybe a show of hands if you guys own a property? Pretty much everyone, that's good. This will be relevant then. So do people know what equity is when I say that? Does that make sense to people? So equity is effectively like the profit that you have in the property is probably the easiest way to think about it. So if it's say it's worth $1 million and you owe $500,000, you would have $500,000 worth of equity in that very simplified example. So the advantage of this through using property is effectively you can leverage off this. That's effectively the main advantage of having that value in that property. So what we're talking about here is what's called usable equity. So in the example before, you had the $500,000 worth of equity, or the profit. However, the usable equity, if it's worth $1 million and you owe $500,000, would only be $300,000. So the reason for that is you have to keep 20% in every property, okay? Because that's your typical sort of deposit. So on the $1 million property in that example, it's $200,000, and the remaining sort of $300,000 is what's called usable equity. Okay. So we've got an example of this on the next page. Okay, so yeah, in this one here, we're using a property value of $800,000, mortgage of $560,000. So the loan to value ratio is what's called is 70% there. So you've got to have a loan to value ratio of 80%. Okay, first of all, that 20% deposit, but anything below 80%, then you basically will enter into what's called a usable equity situation. Now, the advantage of this is the banks will let you loan against the value or that usable equity in that property. So the power of that is effectively you don't have to necessarily save up a whole bunch of cash again to buy another property. You can use some of this profit in this existing property that you've already got as a deposit towards the next house. Now that may cover the entire deposit, possibly. In this example, we probably haven't gone high enough, so you've only got $80,000 of usable equity, but part of that could be used towards the deposit. So you might have that and then another $100,000 of cash or something like that as an example, which you can then use to buy that next property. So it's quite an advantage, it's quite unusual. You can't do this in any other asset class really, but in residential property in Australia, the banks are comfortable with it, and it's a way that you can keep leveraging up that position to effectively accelerate your wealth over the long term. Any questions with that? Does that sort of make sense to people, the power of that? Because if you're not doing this, that profit it just sits in that asset, which is quite illiquid because it might be a home as well. So obviously need somewhere to live and stuff like that too. But you can, if you want to, obviously it does come with a degree of risk, but you can take that equity out to potentially purchase another property and start building your property portfolio. The final thing I'll say on this, so just some things to consider if you are going to think about this. So I've got a graph here as well, which shows how much property has gone up over the last 30 years across all the capital cities. So this is all the capital cities combined here. So this is a cumulative return. So the annualised return is about 5.8%, I believe. Obviously it varies from state to state. So I think over the last 30 years, Perth was the worst performing property market at about 3.8, and Sydney was the best at about 5.9. So some things to consider when you are looking at using equity in your property is obviously what we're referring to here is the liquidity. So property is not a particularly liquid asset. Okay, it requires a lot of money, high transaction costs. So if you are going to purchase another one, make sure you do your due diligence before you go and potentially use some of that usable equity in the existing one to purchase another one, because it can't be undone particularly easily, and it's expensive. Interest rates, so you guys, if you're on variable rates, you would have seen that it's gone up a fair bit over the last 18 months. So make sure you're thinking about that, and if you are doing that purchase, when you're doing your cash flows, thinking about putting some buffer in there as well. So what if the interest rates went up another 2.5% as an example? You know, can I afford that? Because again, you don't want to be purchasing this property then having to sell it a year later. Yeah, the cash flow effects of using equity. So whilst it's great that you don't have to front up this cash deposit, you are effectively borrowing more money, so you will need to be able to cash flow that. If it's an investment property, obviously you will have some rent, will help subsidise that cost, but again, it's making sure you're running your numbers on that too. And then, yeah, I guess the growth of property. So it's been a very, it's been a great performing asset class in Australia over the last 40 to 50 years, and yeah, that was sort of an example of it as well. But remember, it is a long-term hold as well as part of that, over that journey.
Any questions on property that anyone has? More so on that? No? All good? So yeah, good morning guys. Good to see some same faces from last night. What I'm going to take you guys now through is a common question that we get, which is, should I invest money, should I pay off my mortgage or my debt quicker, or should I put in extra into super, or a combination of two or three of these? So I guess before we get started on that, we want to make sure the house is in order. And what we mean by that is making sure you've got a decent cash buffer, okay? So whether that's 3 months of spending, 3 months of income, 10 grand, 20 grand. Some people like to have more of a cash buffer and have it closer to 50. So whatever makes you feel comfortable and happy to sleep at night, making sure you've got that cash buffer. Secondly to that, making sure all consumer debt is clear and paid off. So consumer debt being personal loans, which are generally higher interest rates, kind of 8, 9, 10% plus, credit cards, Afterpay, ZipPay, those sort of things. Once that's done, then also making sure you're aware of your cash flow plan, which I guess is the crux of any solid kind of financial foundation, whether it's property investing or super, is making sure you understand where your money's going and you're not spending more than what you're earning from there. Now, assuming that's all done, we've got kind of 3 scenarios here. So we've got Kate, Chris and Sarah, and all 3 of them have $10,000 spare that they can use, as well as $500 a month surplus. And we're just going to model this out over a 10-year period to see what outcome is the best. So in terms of scenario 1, Kate uses the 10 grand to clear $10,000 off her mortgage, okay, to bring the mortgage down from $400,000 to $390,000. And we're using an interest rate here of 5.64%, which is the long-term average over the last 20 years. So just on that, I think a lot of people, are finding it quite tough out there with the amount of interest rate rises, particularly because a lot of people have bought in the last 5 years and rates have been much lower. But we're kind of back to where the long-term averages are now. So in terms of it going back down to 2 or 3%, that's probably not going to happen for a very long time, I'd suggest. So this is probably more the longer-term average that we will be working with. So that's why we've used 5.64%. Do you mind going back? Sorry. In scenario 2, Chris is going to be investing the money, so he'll put $10,000 into a diversified portfolio. And we just touched on this last night, so that would be something like an ETF, so it's a portfolio of a couple thousand companies in one. So it's not all your eggs are in one basket. And we're going to utilise the Vanguard Diversified Growth Fund, which is a very popular fund that a lot of people may have heard of. That's averaged 8.11% over the last 10 to 20 years, so that's what the return is that we're using there. And then he puts $500 in every month on top of that initial 10 grand. And then lastly, Sarah, she makes a $10,000 contribution to her super, claims that on her tax return. So as a result, she'll get some money back on her tax, okay, because it's a deduction. And then she'll salary sacrifice money into her super so that she's $500 less in her pocket each pay per month, okay? So they're the scenarios. So we'll start off with Kate making those extra debt repayments. So apologies, this is quite wordy, but I'll kind of talk through it. So like I said, her loan would go down to $390, and then she makes $500 per month contributions to her debt. Now, there's no difference if you put it into your offset account versus putting it onto your loan and it sits there in available redraw. The outcome is exactly the same. Putting it into your offset account just generally means it's more liquid and more available, but the end outcome in terms of the savings is exactly the same. So in this scenario, over the 10 years, she's put aside $60,000 plus the initial $10,000. So she's put 70 grand extra onto the loan out of her own money. As a result, it saved her a total of $27,912 over those 10 years. Okay, so her total benefit over 10 years is close to 100 grand, $97,912. So that's the starting point, okay? That's probably the easiest one to implement, easiest one to understand as well, okay? The second one with Chris is now he's investing the money. So he's leaving his debt run its course, okay, just paying the minimum repayments, but now he's investing that extra money. Now with investing, even though it's a better return than the mortgage, so 8.11% compared to 5.64%, Chris has to pay tax on those earnings. So it's similar if you've got money in a high interest savings account, you pay tax on the interest that you make on that, okay? So the same goes with investing. Now, we're assuming here there's a bit of income or dividends in the investment and a bit of capital growth. The benefit of capital growth with investing, same goes with property, is if you hold the investment for longer than 12 months, you get a 50% discount on the capital gains tax that you have to pay. So in Australia, the ATO and the government really encourages people to buy and hold kind of assets as an incentive, and then you'll get kind of a tax incentive as a result. That's a bit of a side note, but in terms of Chris, over 10 years, after paying tax and selling the investment, he would have a tad over $100,000. So he's only actually marginally better off than the first scenario by about $3,000 or so over that 10-year period. But Chris has taken on significantly more risk than the first scenario, right? Because his money's been invested, so there's no guarantee he's going to make 8.11%. That's just historical data. So we've got no crystal ball in the future. If we did know what it was going to do, then it'd be a very easy conversation. So now where interest rates are, it's making investing, I guess, less viable than it was 2 or 3 years ago, because now the gap has really tightened between what you should expect to get from investment versus what the return is from putting extra onto your mortgage. Lastly, extra super contributions. So this is the best outcome purely from the tax savings, okay? So what we're doing here is we're putting $10,000 into super. So Sarah's putting $10,000 into super. Like I said, that will get her a tax return of about $3,500 because she'll claim that 10 grand on her tax, and as a result, she'll get paid back from the ATO about $3.5 grand because that's classed as a tax deduction because she's already paid tax on that money because it's sitting in her bank account. Does that make sense? Yep. For her to be paid $500 less in her pocket each month, she needs to salary sacrifice $763 a month. So it's not dollar for dollar like I was saying last night, okay? you get the tax saving up front. So in super, you pay tax at 15%, okay? And in this scenario, she's paying tax at 34.5%. So she's getting that tax saving up front. So if she salary sacrifices $763 per month of her wage, she'll be paid $500 less per month in her pocket. As a result, that compounding effect, and we've used the same investment as Chris in the last scenario, so the super fund here for Sarah is generating a return of 8.11%, but she's paying less tax on those earnings. Okay, on those earnings, she's only paying 15% tax, so she gets to keep more of that money, versus Chris, who's paying 34.5% tax on his earnings. Sarah ends up with $137,000, so she's more than double better off than the first two scenarios. Okay, so it's a much, much better outcome, but the major downside to this is, depending on your age, it can take a long time before you can actually access this money, and it may not be in line with your other financial goals. So if you want to retire earlier, this isn't the greatest strategy, because yeah, you might have a house that's paid off, and you might have an amazing super balance, but you also need other assets so that you can live off and retire earlier. So to summarise this in I guess, total, with one being, I guess, the best, three being the worst, it's clear that paying off the mortgage has the lowest return just, but its flexibility, certainty and ease of setup is number one out of those three. You're looking at investing outside of super, it's kind of in between. With the flexibility still there, so your money is accessible if you invest money within kind of 3 to 5 business days, so you can get that money back, but you're only getting it back for what it's worth at the time. Okay, so there's no certainty with getting that money back. With the super, it's kind of last apart from the return. So the certainty point in terms of getting it back is just because the government can change the rules with super and push out when you can access it. So that's why it's a little bit different with investing. But the flexibility is obviously not there as well. We can't just take the money back from super. Okay, obviously over the past couple of years, there's been scenarios where we can with COVID and things like that, where you can pull out 10 grand, but I doubt that will happen again, sort of thing. So the flexibility is not there. So if you are, say, in your 20s or 30s, doing the extra super contribution strategy is a good idea, but it's probably not going all in on that strategy. It's probably doing a little bit of that whilst focusing on the mortgage in this scenario.
So just going to number one, paying down the mortgage, this is referring specifically to an owner-occupied mortgage and not an investment loan.
Yeah, exactly right, yeah. So if it was a investment property, then it will be a little bit different. So what we're going to talk about now is debt recycling, which is kind of talking about investing, but it would have a better outcome than paying down your mortgage. The reason being is with an investment property, you can claim the interest on the loan. So if you've got for ease of maths, a $500,000 loan and it's 5.64%, you're paying 5.64% on that amount, which then means that interest you're paying, which will be around 25 grand, you can claim on your tax return. So then it's going to produce a better outcome. So yeah, exactly right, this is on an owner-occupied. Any other questions? Is that surprising to anyone? Is it surprising that super's better? No. Cool. Any questions? Are you happy we move on?
Cool. All right. We'll move on to now a strategy which is called debt recycling. So effectively, this is a situation. So this is basically almost a bit of a combination of 1 and 2 that Scott was going through before. So this is a situation where you would have typically your owner-occupied house, and what you're simply trying to do is to switch the debt from non-deductible debt, which basically means you can't claim the interest on your home mortgage in your tax return, and switching it to deductible debt, okay, which is investment debt, which means you can claim the interest on that loan. So yeah, generally this is done with your owner-occupied. Some other things to consider before you potentially attempt a strategy like this would be that the house that you're in, you're comfortable with, and you're going to be there for a while as well, because unwinding this can be a little bit messy as well. So you generally want to be there for a while, typically too. So how does it work? Effectively, like it was Kate in scenario 1, you would take an amount of money, pay down your non-deductible or pay down part of your mortgage, and then you would effectively redraw that back. Okay, so you say you pay the 10 grand down, you then take the 10 grand back. Okay, but instead of just leaving that back against your mortgage, you would take that 10 grand and you would invest it elsewhere. Typically, how this strategy is done is that invested in shares is the most common way to do it, because it's the easiest way, and then you can do it in smaller chunks, right? Because it's, say, 10 grand parcels at a time or 100 grand parcels at a time, as an example. You would redraw that back out. That investment is then going to pay you, if it's shares, it'll be dividends as an example, so you get some income. You'll hopefully get some capital growth as well, but part of the return will be income from that, which you'll then effectively take to then pay down more of your non-deductible debt, so say another 10 grand chunk, which you'll then withdraw back again and then reinvest. So at no point in time are you increasing your debt level, okay? So you're not leveraging up. So similar to what I was talking about with using equity in your house before, that would be taking on more debt, so that would be leveraging it. This is just simply swapping the debt, okay, or recycling it, hence the name sort of debt recycling. So you take that income from the investments, pay down more non-deductible debt, redraw that back out, and then reinvest that back into an investment like shares until you've effectively swapped the entire mortgage from being non-deductible to now fully deductible. Okay, and then from there you would continue to pay it down. So at the end of, say, the 15, 20, 30 years or however long you're planning on doing this strategy, at the end of that, the house would be completely paid off, and you would potentially have then an $800,000 or $1 million share portfolio or something like that as well. But it effectively, by doing this, it accelerates the repayment of that, because the interest is becoming more and more deductible along the way. So you're getting a discount effectively on your interest rate, plus you're then getting the income from the investments as well, and that's continuing to grow as part of this too, the bigger it gets. So Chris, I think it was in example 2, he wasn't quite doing this. He was just simply taking his spare money and investing it. This would be basically turbocharging that strategy, in that he's using then debt, so he's getting that tax deduction, and then investing that spare money on top of that. So basically what it would do over that 10-year period using the same numbers is it would approximately increase his profit by about 10 grand. So the difference between scenario 1 and 2 was about a 3 grand difference. Doing this strategy on those numbers over that 10-year period would increase it to about 13 grand.
So, question? Oh, yeah. So that makes, yeah.
You're saying that it is for owner-occupied houses, that's where you're currently...
Typically, yeah.
What happens when you go from owner-occupied to starting to rent? How would you change the whole debt recycling thing?
Well, you wouldn't necessarily. It just means that if you say you started this strategy, okay, and maybe 100 grand of that is now invested in shares or something like that. Say it's an $800,000 mortgage, 100,000 of it is deductible because that's in shares, and then you decide to switch that property from owner-occupied to an investment property. It just simply means that the remaining 700,000 would now become deductible.
Yeah, which is why Alex was saying if the plan is with your home to turn it into an investment property in the next couple of years, you probably wouldn't worry about this strategy, because the loan is going to become deductible pretty soon anyway when you switch it. You don't need to tell the bank or anything like that, hey, now it's an investment property, because if you do that, they'll probably bump up your interest rate. So you just stay quiet and just tell your accountant that it's now an investment property. But yeah, this is more if it's the home for the foreseeable future, and things can change, right? And what that will mean is then the rest of the loan will switch, like Alex said. But it just means that, yeah, it's a riskier way of doing it. It's a more aggressive way, but it does have a lot better benefits and outcomes if you do kind of stay the course with this.
Yeah, if you can stick to it. Yeah. Any other questions with that?
How does it become non-deductible?
You mean deductible?
Yeah, deductible, sorry. How does it become deductible from...
Because you... Yeah.
Like say, for instance, I've got a house where I'm living out in the wilds in Tasmania, and it's like $250,000
Because you're then using that money for investment purposes. And under tax law, it says if you borrow money to effectively buy an asset which is income producing, which shares would be, the costs are now deductible of that. No, you could invest out of your offset, but that would just be like what Chris was doing in example 2. That's just putting cash into an investment. Yeah, but what you could do is take money out of your offset, pay it into your mortgage, and then redraw that back out. So you've got to change.
So it's just like you sit in there for 24 hours and then the next day you go, right, I want to invest in this ETF and off you go?
Yes, yeah, effectively that is correct. Admin-wise, it is better if you can then sort of split the loan off. So typically you might do it in 50 or 100 grand chunks, so it's a bit more clear that this 100 grand, or basically split the loan back off, so take that 100 grand back out in a separate loan as an example. Then it's just a bit easier to track the interest on it and stuff like that. But yes, you can 100% do it as you said as well.
Any other questions? Yeah, all good.
Cool. All right. We'll just move on to the 4th topic then.
Yeah, so just wanted to explain a bit more about putting extra money into super, given it was the best outcome, okay, and kind of the reasons and some of the options here with the different superannuation caps that we have available to us. So the reason why you put more money into super, the tax savings, so hopefully that was clear from the scenarios before. It will mean then you have more money in retirement. So as the government is phasing out the age pension, that's becoming less and less and harder to obtain. We all need to become self-funded. So it just means that we will have a better retirement. And the one thing that I guess a lot of people miss is when your super fund, when you get to retirement, so whether that's age 60 and you fully retire at the moment, or you attain 65 and still working, you can change your super into what's called a pension. Okay, so it still stays in the same environment. So if you're with Breast or Host Plus, nothing will change there. It will still look the same to you, but in the background it will turn into a pension, and what that effectively means, it's now in a 0% tax environment. So what that means is when it makes money for you, you don't pay any tax on that. Whereas at the moment, your super fund, if it makes money, you'll pay 15% tax on those earnings. Okay, so that's the long-term benefit of super, is when you reach retirement, you don't pay any tax on earnings up to a certain value you have in retirement. Does that make sense? Yep. So in terms of the types of contributions you can make, so there's a few more than this, but these are the 3 main types that we see. Okay, so concessional would be the ones that most people have heard of before. So that's your 11% of your salary, so your SG, which is going up to 12%, like Alex said last night. Can be salary sacrifice contributions, or it can be these one-off contributions like we did before. They all go under the concessional contribution cap. So at the moment, that's $27,500, unless you're in an untaxed fund. I think, Gail, you mentioned last night as an example. Now, with this concessional cap, some people haven't hit the limit of their cap. Okay, not a lot of people will hit that limit of their cap unless they're salary sacrificing. So what you're able to do nowadays is you can use what's called catch-up contributions. So if you want to put a lot of money into super, so let's say you've had a large capital gain, you've sold an investment property and you've made 50, 100 grand, and you're worried about the amount of tax you're going to pay, one strategy could be to dump a lot of money into super, which is then a deduction, which then offsets your capital gain. The problem is, in the past, that putting extra into super, you've been limited to $27,500, okay? And if you're earning, say, 100 grand, you already have at least $11,000 from your employer going in. So then that brings it down to closer to $15,000 of a cap left. So what they've brought out is a catch-up contribution rule. So you can go back on the last 5 financial years and see how much gap you have between the cap and how much went in, and then you can make a catch-up contribution in one go to top up the last 5 years in caps. Does that make sense? Kind of, yep. So that's the concessional cap. In terms of the non-concessional, so this is where you can just put extra money in from your bank account. So in the example before, you could just put 10 grand in, not claim it on tax, so 10 grand just goes in. The benefit or the reason why you would do that, it just means you'll have more money in retirement, and that $10,000, when it makes money, is only paying tax at 15% compared to your marginal tax rate of, say, 34, 39%. Spouse contributions, so if your spouse or partner de facto earns under $37,000, you can make up to a $3,000 contribution into their super fund from your bank account, and then you'll be entitled to up to a $540 tax offset. So what a tax offset is, it's better than a deduction. An offset effectively means if you owe $540 in tax, you won't owe any tax. It just comes off your tax bill or gets added to your tax return. Okay? So it's not a huge saving, but it keeps, say, a non-working spouse or someone on maternity leave, their super ticking away as well. I guess just like I was going through before, the difference between accumulation or super, which we're all in at the moment, versus pension, which we get to when we retire or reach 65. The main differences are you able to contribute? So once you reach pension age, you can't put any extra money in, okay? So once you kind of change that to a pension fund, you can't put money in. If you are still working, you would need to leave a accumulation account open, so you would be running 2 accounts, okay? The tax rate is the one though. So 15% at the moment on accumulation, 0% if you're in a pension fund. So let's say you retire, you're 65, you've got $1 million in super. That changes to a pension fund, and that pension fund earns $100,000 over the course of the year. So a 10% return, which isn't out of the realms of possibility. You'll keep that $100,000 in your pension fund. You won't pay any tax. If it's in super, you would have paid $15,000 in tax. Okay, so you just get to keep more of your money, which as you approach retirement, why super is more beneficial to try and get most of your money, most of your wealth, most of your assets into the superannuation environment. Because if you retire and you've got, say, 2 or 3 investment properties, you've got share portfolios, you've got cash in the bank, that's still earning you money. Even though you're not deriving an income from work, you're still earning money from assets, which if you earn over, say, $20,000, you're going to start paying tax on that income or those earnings from your assets. So that's why, I guess, trying to get as much money into super as you approach retirement at the moment with the current rules is the best thing to do. Yeah.
Will the new caps that are on super capping at $3 million?
Yep. Yep.
Well, that's inclusive of the pension funds as well.
Yep. Yes, but so what they've brought in this year's budget. People may have seen there's a $3 million cap on super. So what that means is if you've got over $3 million in super, which if you have, congratulations, instead of paying 15% on your earnings, you'll pay 30% on your earnings. Okay? So
after that $3 million?
After, yeah. So your first $3,000 is quarantine, 15%, after you pay 30%. So again, it's just going back to taxing the higher, kind of the wealthier people. There's not that many people, as you can imagine, in that space at the moment, but I do believe it's not indexed at the moment. So what that means, it's just going to be a stagnant rate for the foreseeable future at 3 mil, whereas a lot of things in Australia will rise with kind of indexation. A lot of people that work, say, for 35, 40 years will get close to that $3 million mark for sure. Because now that it's going up to 12% of your wage, most people now will be earning $100,000, $120,000 is pretty common now. So 12% of that is a lot of money going in over a 30, 40-year period to compound, and as a result, a lot of people will get over that point. So yeah, it's not really going to affect anyone at the moment, but will do probably in 20 years' time if the rules don't change.
It's almost a future-proofing for the government for people.
Yeah, that's right. They sort of push it through of, it's not going to affect anyone, guys, but yeah, in 20 years it will affect a lot of people.
We just wanted to show, I guess, the longer term impact of salary sacrificing to super. So why would you start when you're younger? So this person earns 120 grand a year and then just putting the $500 a month into super, so 5% of their wage. They've got a super balance of 112 grand at the moment. They're 36 years old. over the journey from when they get to 65, that makes a $500,000 difference just through doing $500 extra a month. Now, the effect that has on their take-home pay, if you can just click, the effect that has on their fortnightly take-home pay is around $150. Okay, so their current take-home pay based on 120 grand is $3,387. Doing $500 a month salary sacrifice will only reduce their pay by $150 a fortnight. Now, in the time we're in at the moment with cost of living increases and stuff like that, that may not be possible, but it's just about thinking about this. If we can start doing it in some regard earlier in life, it does have a massive compounding effect and makes a huge difference. And I guess to our point before, like this person, even kind of with no salary increases and things like that, and not doing the salary sacrifice, is still getting to kind of 1.6, 1.7 mil. So if most people are going to stay employees for the rest of their lives, they're going to have 12% of their wage at least going into super. It's going to become one of your biggest, if not your biggest asset outside of your own home. So that's why, I guess, similar to last night, we just say it's important to take care of it and be active with it as well. Any questions on contributing super? Yep.
It's like salary sacrifice into super, does that, like, you know how there's salary packaging caps? Like, is this on top of?
Yeah, it's not, yeah, so it doesn't count towards like your living expenses, or you're talking about that, rent and mortgage repayments. So most people probably have $9,010 as a cap, or if it's a non-for-profit, it goes up to $15,900 as a cap. That's not included in those caps. So this is outside of that. Where you need to be careful here is that $27,500 superannuation cap. So a different sort of cap, yeah. You can do either. So in this scenario, it was doing it just with payroll, or I think we talked last night about doing it through your salary packaging provider. Maxio was the case we used last night. Obviously, that comes with an extra fee for them to do that. Or you can just do it as a one-off lump sum, $6 grand a year, claim it on your tax. The outcome is the same. There's just a bit more administration for you to do as a result. Yeah. Does that answer the question? Yeah.
Okay, cool. All right, we're almost done. We'll just finish up by running through self-managed super funds. So before I run on this, though, I actually just wanted to go back to that debt recycling strategy that I was talking about before, because one thing I forgot to say, which I think is worth mentioning, is that's also a great strategy that you can utilise if you're not interested in investing in property outside of your own house as well. So if you've got your own home and you're not too interested in buying other properties, it's a great strategy that you can utilise to still build that investment outside of just your own house and your super as well. And it's also a really good way of doing it because you can borrow money for shares. So say you're like, I've got my house, I don't want to buy any more properties, but I am really interested in shares, and I understand how debt and leveraging works, so I want to borrow some money to do that. If you were to go to the bank and say, look, can I have $500,000 to put money into shares? Well, they may potentially give it to you, but if they did, typically the interest rates that they lend that at is a lot higher as well than what they'll lend for property. Okay, so using your own mortgage to effectively fund your own gearing strategy through shares, not only is it good because it obviously becomes tax deductible, as I explained before, you often get a much lower interest rate. Okay, so it might be 5.5%, which is the owner-occupied rate at the moment approximately. If you were to do it just purely borrowing from the bank directly to go to shares, it'll probably be about 7.5 or 8% interest as an example. So it was worthwhile mentioning that.
Does anyone here have a self-managed super fund before we get into it? No.
Cool, so this is a question we get asked quite a bit in our line of work, so we just wanted to run through, a bit about what it is, how it works, the pros and cons, when it might be applicable, that sort of thing. So a self-managed super fund is no different in terms of legislation from a normal or ordinary super fund. However, it allows you to typically take more control of where your money is invested within super. What often comes with that as well is access to other asset classes too. So one of the key sort of differences is you can buy a residential or a commercial or a direct property through a self-managed super fund, whereas you're not able to do that in a normal super fund like Australian Super, as an example. So that's one of the sort of the key sort of differences here. You just have that more control, a little bit more flexibility as well. Okay. What we believe is the criteria for having your own self-managed super fund. So they're relatively expensive to set up, and they have ongoing costs as well. So as a general rule of thumb, and this is very general, you would need, in our opinion, to have at least sort of $500,000 in super to make this justifiable from a cost point of view. You need to have quite a good understanding of how superannuation works, the legislation, the laws behind it, because ultimately you are now the boss of it, you're in charge, so the buck stops with you as well. We would recommend that if you are running your own fund, you engage with an accountant or a financial advisor or both to help you run the fund and the compliance of it. And ultimately as well, the main reason that you're having it is you want to invest in something that is unavailable in an ordinary fund, like a direct property as an example, or potentially some artwork or some sort of obscure asset class which you can't get through a normal fund.
And with that 500 grand, it's combined, so you can start a self-managed super fund with multiple members, okay? Usually it's done kind of with two partners, two spouses, but you can do it, with siblings we've seen before, even friends, okay? So the maximum members you can have at the moment is 6, okay? And when we talk about 500 grand, that's a collective unit, okay? So I might have $50,000, Alex might have $300,000, and our best mate has $150,000. Now we can combine that, and now we've got $500,000. Now, it's all managed as well, so I've only put $50,000 in, so if our fund makes a 10% return, because we've invested in property or whatnot, I'll only get 10% of my $50,000. I don't share equally in thirds with everyone else, just on that as well.
So the key pros of having a self-managed super fund, we've sort of touched on a few of these already, but ultimately, it's control and flexibility. So you have much more control over where your money is invested, and therefore much more flexibility over that money as well within your own fund. Investment choice, so as I've said a few times, you have a much wider range of what you can invest in if you are doing it yourself. And then as Scott sort of touched on then as well, you can have family involvement, or you could do it potentially with a bunch of mates. You can have up to 6 members in a self-managed super fund as well, which may allow you then to potentially pool funds together to potentially buy something like a commercial property or something like that as well, if that's of your interest.
Yeah, so it's quite common that business owners will buy their own property, their own premises in their self-managed super fund, okay? You can't get a self-managed super fund and then buy your own home and live in it, okay? It needs to be at what's called arm's length, so it would need to be an investment property, but you can get commercial premises that you then rent to yourself, so then the business then pays rent into the self-managed super fund. And then the self-managed super fund, if it's got a loan, will then use that to pay down its loan.
So I guess 3 of the main things to be wary of if you are looking at doing a self-managed super fund in terms of the cons. So time and effort. So you are now in charge of the administration of the fund, whereas if you have an ordinary fund, that's all taken care of for you and stuff like that. So you will need to lodge a tax return as an example. So that will need to be done through an accountant. You'll have to have your fund audited as well as an example there. So there is a lot more time and admin burden potentially on yourself. You can obviously outsource a lot of this too, but again, you have to be responsible for making sure that that's been done and all the boxes have been ticked correctly. Legal and compliance responsibility. So as I mentioned before, the buck now stops with you. So if you stuff something up, potentially get yourself in a bit of hot water there. And you do need to be really careful when you are running your own fund that you're aware of what you can and cannot do. And then lastly, as I've already touched on a little bit as well, the cost effectiveness of this. So self-managed super funds can become very, very cost effective, more cost effective than an ordinary fund, but typically you do need to have a higher balance to sort of get those economies of scale to make that more cost effective, or potentially have multiple members sort of pulled together to get that overall balance up, which can then bring that cost down.
Yeah, and I guess to put that in some numbers terms, like the setup of a self-managed super fund, an accountant will generally charge $2,000 to $3,000. The ongoing tax return and audit will cost the same, which you have to pay on a yearly basis. So if you've, say, got $100,000 in super and you convert that to a self-managed super fund, you're paying 2 to 3 grand a year, which is 2 to 3% of your balance. Whereas if you're in Australian super, you're only paying 0.8% of your balance. And Australian super does the tax return, they do the audit for you and all of that, because they've got the economy of scale there, so it's a lot cheaper for them to do, so they pass on a lower fee. So that's where we're talking about, that's where you need more money for it to be cheaper, because if you're being charged, say, 3% of your balance, what we were showing before is outcomes of, say, 8% on investment returns, and that is kind of the longer term history. You're not really making as much money now because a lot of it's getting eaten away in yearly fees and costs as a result.
All right, final thing we'll touch on is just borrowing to purchase in a self-managed super fund. So you can borrow money through your self-managed super fund to purchase property, whether that's a residential or a commercial property. Things to be wary of this is typically you will again pay a higher interest rate than if you bought the property yourself. So the banks deem this a little bit more risky. It's a lot more compliance work for them typically as well, which is why they then charge a higher interest rate normally. In terms of the deposit amounts required, so it is still relatively similar to what you'll have in the normal owner-occupied space. You can self-lend as well to your own self-managed super fund, so you could take your own cash and then lend it to your self-managed super fund to then allow it to buy a property. However, they deem the interest rate that you have to charge on that to your own fund, along with the deposit amount required is a little bit higher, sitting at 30% there, whereas it's typically 20% in the owner-occupied space.
So the key benefit of this, which we've utilised for some of our clients before, is that you can become the bank and lend to your super. And then, it's being charged an interest rate, but you're collecting that interest rate from your super effectively. So you're not paying interest to a bank, but you're still getting access to purchasing property in your super. So that's probably more down the track when you're closer to being debt-free, a lot of equity in your property, so you do have funds to lend in to your super fund, but that can be a really effective way of building out your wealth in your super through property if that's something you want to do.
Yeah, so I guess to summarise it, they definitely have their place and they can definitely be quite an advantage in a lot of situations as well, but you do need to be careful and just consider your own circumstances and do make sure it's actually going to be worthwhile for yourself, and it's as opposed to just having a more of an ordinary fund, which is obviously going to have lower costs for lower balances as well.
Yeah. So unless, I guess, you wanted to buy property, there's probably no place really for a self-managed super fund, because most super funds now, and again I'll use Australian Super, you can buy direct shares with them. So if you want to buy BHP or Westpac shares, you can do that with an ordinary fund now. Go back 10, 15 years ago, you couldn't do that. So that's where self-managed super funds used to have a bigger place, because people wanted to buy direct shares and have more control, and they needed a self-managed super fund, because ordinary super funds only offered go in the balanced option, go in the high growth option, and that was it. But nowadays, a lot of super funds will enable you to buy direct shares, which then makes self-managed super funds even more redundant unless you're wanting to buy direct property.
Cool. So that's it from us, guys. Thanks for coming out this morning. If you do want to get in contact with us, we've got our website up there. Otherwise, we'll be sticking around for the next 5 minutes or so. Unless there's any other questions that anyone wants to ask in front of everyone else.
Of super in general? Defined benefit scheme.
Sorry, you would...
There's a defined benefit scheme
Yes?
when you utilise super.
Yep.
That we've got with AB.
Yep.
Very best practices. Your last 2 years of working life, you get 7 times that or something like that.
Yeah, so that's quite different from, I guess, a standard super fund. Okay, and yes, they use a relatively complex formula to figure out effectively what you're going to be paid once you go into retirement, and it is often a combination of your last couple of years' salary, average like that, times by your number of years in that fund as well, to effectively then calculate your benefit. So that is quite a specific thing. I would recommend that if you are getting close to retirement in that sort of area, that you do get your own advice to make sure you can maximise whatever that benefit's going to be. But it's quite different from a standard super fund where you build up your own funds and then effectively you draw down on that. This is basically pooling a whole bunch of money together, and then when people retire later on, the people still coming through effectively fund their retirement going forward. So they're not that available these days as well. They do still exist, but they are being largely sort of phased out in other areas too. But they're a good thing though. If you've got one, it's a very good thing to have. Yeah.
Yeah. And I guess you wouldn't really want to go partially into retirement because of the calculation is it partly on your final year's salary and stuff like that. So a common mistake sometimes we see, depending on the scheme as well, because each scheme's different, is someone will go part-time 3 days a week as they head towards retirement. That actually has a detrimental effect on their defined benefit pension that they can collect because of the calculations based on like your last few years of salary, which is now obviously less. So that's where you, unfortunately with those sort of schemes, it tends to be you need to work full-time and then cut it off rather than ease into a retirement space. Yeah. That's all right. Any other questions, guys? No, all good. Well, enjoy the rest of your day. If you don't mind just giving us some feedback, it just helps with any future talks that we do, whether some of this was relevant, some of it wasn't. Appreciate any feedback you guys have. Otherwise, have a good rest of the week and look forward to having a beer with you guys or a wine on Friday. Thanks for your time. No worries, mate. Thanks for coming again. Appreciate it. Much on today? Chill out. Yeah. Take it easy. Yeah. All right. Take it easy, mate. Thanks.